All right, thank you for having me here today. If you don't mind, I'm going to just slip off my jacket. I'm about 6 weeks, maybe 8 weeks ago, I had the opportunity to speak to a group of students who were touring at Mercy that day, and we got talking about patient logistics and our goals and accomplishments so far. So Cassandra asked me to come back. I'm glad to be here. Whoops. So what is patient logistics? You know, there's a definition from a dictionary, but patient logistics is the detailed coordination of a complex operation and system to manage patient throughput from pre-hospital care, emergency and acute care, on to post-acute care. It's a lot like herding cats. Everybody's going everywhere. No one's really in charge. My responsibilities are for EMS, our air EMS system, emergency and trauma center, all inpatient medical program services, Eady physicians, hospitalists, intensivists, neurohospitalists, trauma, stroke, care management, care revolution, home health hospice, DME, patient placement staffing, nursing supervisors, and communication center. There's not many of me out and around that I am aware of, so it would be very, excuse me, it'd be different person to person. Oh, what I do, did I break something?
No, it's not you, it's me.
Are we breaking up? You get it? It's not you,
we are
it's
breaking
me.
up. Yeah. Yeah. Okay, can you guys see it now?
Yes, thank you.
Sorry.
This is where we were. So these are just the areas that in the hospital that I have responsibility for. So it is, again, really everything from prior to the patient coming to the hospital or en route to the hospital, also to the post-acute care side, whether it's home or they're going to a SNF or rehab, home health, something like hospice, something like that. What is our bias for action with patient logistics? Well, we have Medicare excess days is a nationwide issue that continues to only increase. At Mercy in fiscal year 2018, we had 3,500 excess days that equated to about $8.75 million that we did not or were not able to move to the bottom line. That's a lot of significant money that have out there that your hospital is spending on patients that is not based necessarily on their acuity. Length of stay was 1.1 days above budget and was continuing to trend upward. We have a length of stay budget of 4.60 days, and when I joined Mercy in January, we were at 5.7. There's other reasons that we want to really focus on moving the patient through the system. Discharging patients earlier keeps patient throughput moving forward in other areas as well. Emergency department, PACU. In August alone of 2017, the emergency department had nearly 350,000 boarding minutes. Boarding minutes is from the time the admission order is placed until they leave the ED to go to a bed. It's purely because patients were not moving through the system during the day and getting moved from the ICUs to the med-surg units, to the med-surg, to discharge, or to Marion Center, or wherever they needed to go from there. So it was all just stacking up these admissions, tying up emergency department rooms, slowing down their resources, making the PACU keep people instead of for 2 hours for 23 hours until the following morning. And then you just repeated those vicious cycles. Direct admissions from other hospitals, our referral business, which is very important to us. We would call them and say, we have you on a waiting list. We hopefully will get you in the next 24 hours, but you guys are either going to have to hold and stabilize or send them somewhere else. Well, a lot of these hospitals are tiny places that have very limited resources. The only thing they want is that patient out. And so they end up sending them away from Mercy to other facilities. patients in clinics who needed direct admissions, we'd say, go home and we'll call you. So it was a crisis of enough of an issue that they reached out to me and said, hey, want to come work with us and fix this for us? And so we got started on that. Other good reason for our bias fraction is discharging on the right day to the right location for the patient decreases risk of hospital-acquired infections, pressure ulcers, medication errors, and increases patient satisfaction. So I try to do this in a way that y'all might be familiar with: assess, diagnose, treat, and monitor. So when I came to Mercy, there was no hospital-wide system for identifying patients who had complex need. Everybody knew they existed, but no one was bringing resources together to discuss those patients and to look at what opportunities did we have to keep them moving. Whether it was medical issues, nursing issues, psychosocial, family, you name it. Many times we were not even addressing any of those issues until the day the physician said, okay, it's time for this person to discharge. They don't meet, or the case manager would say they no longer meet acute care inpatient requirements. They got to go somewhere. And it would be on that day that we would start trying to deal with all these issues, and it could be 3 or 4 more days before they actually left. Those are those excess days we talked about in the beginning that added up to nearly $9 million. There was no one person in charge or held responsible for managing these patients. There was no focus at all on patients, on complex patients and their unique needs. I said that just diagnosed as a multi-system organ failure, and treatment is multi-stage. The first one was to implement TEMPO. TEMPO stands for Team Engagement to Manage Patient Outcomes. It is the patient throughput process that we have put in place on every single one of the nursing units at Mercy to ensure that we were focusing on every patient every single day. And the entire focus is, what is the barrier to this patient moving forward to being discharged? It is a nurse-run, nurse-managed system with input from care management, from the therapies, other services. Many times the nurse practitioners will attend as well. And the reason it's a nurse-managed system is because nursing is the only one that's there that's 24 hours a day and knows that patient typically the best. The chief nurse, though, owns TEMPO for the entire hospital, and therefore drives the system with support by case management and the other clinical departments. My role is to support the chief nurse in care management, leadership in carrying out TEMPO and ongoing efforts. The nurse manager owns it at the unit level, but it's typically the charge nurse who runs the TEMPO huddle. And so it is the entire focus of the group. It is a group of people standing around a TEMPO board, which you'll see on a slide in a minute, who are going by every single patient, talking about, we're not talking about he's scheduled for a CT today, or gee, his urinalysis came back and he's got, you know, too numerous to count RBCs in it. It is, what is the barrier to discharge? He doesn't have any relatives to go home to, and his cognitive level is such that we can't discharge him safely home. We're looking for, you know, family, et cetera, et cetera. So it is based on the barriers to discharge, whatever they should be. Takes about 15 minutes to do a unit, even with 30 or 40 beds. We now do it 3 times a day. And initially, we only did it between 7 a.m. and 9 a.m. Takes that long for every unit to get through it, about a 15-minute process. Some units used to do what they called a huddle. They'd do it at 11 o'clock or 1 o'clock, and they'd talk about a patient here or there. Well, if you're doing it at 11 and 1, and you're identifying that patient has needs to be completed before they can discharge, I can guarantee you they're not going home that day. If they need an MR or an echo or something like that, and it's 1 o'clock before you're even identifying that, it's probably not going to happen unless it's stat. And even if it's stat, it's going to get in a line of who's more stat than who. So we do it before 9 a.m. Then at 2 p.m., the charge nurse and the case manager and social worker gather around the board again to look at what they've identified during what they identified in the morning as barriers what has been done with them. If it was that they needed a consult to ID, have we put that consult in? Has ID come and seen them yet? If it is that they need an MRI, did we get it ordered? Is it scheduled? Do I need to call MRI and say, hey, once you do this MRI, this guy can go home. I need you to move him up on your priority list. And then again, it's done around 3 a.m. now with the charge nurses and their staff at that night to say, okay, what have we seen change in the last 12 hours? Are these people still ready to go? Are these people not? If ones that we think are going to discharge in 24 hours, are we ready for that? Since we have implemented the 3 a.m. one, we have seen our discharge by 11 a.m. go from 20% to 49%. And the 3 a.m. we have only been doing for about a month on some test units, and it's going house-wide the 1st of October. This is what a tempo board looks like. So it shows initials, patient initials, room number. Red means not ready to discharge for 2 days or greater. Could be a new diagnosis. They could be medically unstable. So trying to diagnose them. Yellow means we think they're going to discharge within 24 hours. Crucial period of time of if they're going to discharge tomorrow, what do we need to accomplish between now and then? And then green is we think they can discharge today. And our goal there is how many can we get out before noon? This is their length of stay. This is their geometric length of stay. That is a Medicare term based upon their DRG. And that is what our payment is based upon. So when we exceed it, we turn it red so everybody knows. Then there are the barriers. And so if there was one on here that said, let's say PT, OT, evals, when those were done, PT or OT would come up and just put a line through it. They wouldn't erase it. We want to know that it was, we had it there and that it was taken care of. Every unit has this. We are testing electronic on a couple of units right now to see if we like that better to move that way, because it can pull information from Epic. So that was one step, was implementing tempo. The other was me developing what I called a complex case meeting. That's where we bring a group of people, myself, case management, physician advisor, rehab leadership, therapy leadership, finance side, legal side, ethics, and the social workers and the case managers to look at patients that we've identified as having got complex care needs in the hospital. Our criteria for those patients are length of stay already at 10 days or greater, charges at $250,000 or greater. They're self-pay patients, they're charity patients, they're complex discharge needs. Most of those y'all deal with family issues. They're very social issues. They're on IV antibiotics for greater than 7 days, IV chemo or immunotherapy for 7 days, greater for 7 days. They've been in an OB status greater than 48 hours, or they have no discharge plan. So we created these criteria. Epic goes and pulls this for us, and once a week we sit down as a table with the care managers and social workers and work through those patients. First time, and I've got those statistics for you on the first time. I was not a member of Mercy Administration when I implemented this for them. I was actually the CEO of Mercy Rehab Hospital, but I was seeing the impact on my patients over there of them not being aware of this. And so I helped them implement this about 1.5 years ago. And their administration, a couple of their members of their administration, their COO and their CFO came to the first meeting. The first meeting we had of this, the patients listed on it, total charges around $8.5 million or so. They had no idea that they had these patients in their hospital with these types of complexities and that they weren't moving along in the system. So it's been great. It's been a great asset to us, and I'll show you some of the outcomes it's gotten. The other things is I've implemented are some letters of agreement. So we have patients in the hospital, every hospital, acute care hospital has this, who no longer meet true criteria for inpatient stay. So that means we're going to stop getting paid when they no longer meet that criteria, but they have a prolonged need for some level of care. whether it be SNF care or rehab or possibly even home health hospice, but it's usually related to something like they have complex wounds that continue to need nursing management of those on a daily basis. They need to be on IV antibiotics for 6 weeks because they've got infected heart valve from drug use. They have trach advancement. They have feeding tube issues. They need O2 to be able to go home, but they don't meet the criteria to stay in the hospital. So in the past, until April of this year, we just kept those people every day. And then minimal cost on a nursing unit at Mercy per day average is $2,500. So we were spending a minimal of $2,500 to 2 or 3 times a day to go in and do wound care and probably manage their pain with oral pain meds. That's it. That's all they needed from us. So I came out and said, you know, there's better ways we can do this. And so I went to a skilled nursing facility that has a good reputation for its level of care and also has 100% conversion rate from Medicaid pending to Medicaid status, meaning that they're going to get paid for that patient care. And I said, hey, how about on these people who meet Medicaid criteria, if you take them when they no longer meet inpatient criteria, you provide the service to them, we pay you your Medicaid daily rate, and then if the patient converts back, you would just refund us the money. If they don't convert while they're still needing care, then I'm going to pay you for that. And this hospital, or this skilled nursing facility said immediately, yes, let's do it. And so we started that in April, and it's been a great success. And just in August, we added rehab in that same situation. Another thing that I thought was extremely necessary, especially in a hospital as big and complex as Mercy, was that we have a physician advisor to care management. So I created a position called physician advisor. It's the first one in the entire Mercy system where there is a full-time physician who is focused on patient throughput, as well as me and the care managers and the social workers, et cetera. Their nickname for her is the discharginator because she loves her real passion. She was a hospitalist and a neurohospitalist for 16 years at Mercy. But she was always one, when she admitted a patient, would start very openly saying, okay, what are we going to do for this person to get them out of here? How are we going to get them out? What do we need to do between now and then? So she provides physician oversight, consultation, recommendations for action. She has no fear at all of stepping herself into the middle of a case and saying, guys, what's going on? Why is this patient still here? They're stable. You know, this issue, why are we not dealing with these things and making a plan? She's also the link between the case managers and social workers and the medical staff. So if they have someone who they've made a recommendation to and maybe they're getting blown off or it's not getting acted first of all, that care manager can call the physician and she will then step into that situation to help move that patient along. She also works really well with the different departments to try to remove institutional barriers. What we found when you look at, I mean, look at these, we're talking a lot of these about consultations, we're talking about testing. We are a level 1 trauma center, we're a level 1 burn center, we're a level 1 stroke center, STEMI center, and we have certain testing that you could not get on the weekends. Well, we don't want to pay for somebody to have to come in. That's fine. We don't have to pay for somebody to come in, but we can pay for them to be on call, and we can create criteria for when it's appropriate to have it on the weekend, those kinds of things. And at the same time, is that test even necessary before the patient goes home? So she deals with a lot of those types of things. And you know, there are certain groups, surgeons. Who wants to be a surgeon? No one? There are certain groups, surgery is one of them, that once they do their surgery, they like to wash their hands of the patient and say, okay, medicine step in, hospitalists step in and take over. And so that can delay care a lot. So she's working specifically with my trauma team and looking at how they can keep patients moving fast through the system. Some of our outcomes. In 5 months, we have decreased our length of stay by 1.2 days. Medicaid excess days reduced 25% in the last 6 months of the past fiscal year, which was 18. It should have been more, but it was new systems putting in place. Not everybody ramps up at the same time, but we reduced lost Medicare payments by about 2.2 million. We reduced patients' length of stay greater than 20 days by 60%. It was amazing to me the number of patients we had that were in the acute care for over 20 days, and we have reduced that significantly and will continue to. There it is. The first complex case meeting week total charges we had were 7.7975 million, and now they average approximately 3 million or less. And we will probably average 25 acute care, med-surg, ICU level patients, and 10 acute psych patients that we go through in about an hour to an hour and a half. So here's what, when I put in that letter of agreement with the SNF, in 4 months, I paid them $33,000 and they saved me $536,000 at a minimum in hospital costs, nursing overhead, those kind of things. And then we talked about earlier, case managers and physicians seek out the physician advisor for her help in moving patients forward. Thank you. What kind of questions can I answer for you, if any?
Let's see if we have some in the chat.
Okay.
So I was impressed that you guys started having a physician advisor.
Yes.
I think it's a really cool role. I was actually on the hospitalist service at Mercy a month ago.
Oh, were you?
And,
Okay.
yeah, and so I got to hear from docs about certain gaps that are making, especially they talked about like the discharge lull over the weekend.
Yes.
And how like with PT and OT, how they don't have enough staff over the weekend because their department was cut shorter. And because of that, they have to do, like certain departments are lower priority for discharge. So we had so many patients on cardiac that just sat there and they could have got discharged
Absolutely.
Thursday night to get discharged until Tuesday morning.
Yeah.
And so I was wondering, it's wonderful and it's fine and good that you guys have like your job and the consultant, but do you have some sort of where you can bridge that gap to where you're either at advisory or consulting to the people in the room making those funding decisions for department?
Yes, because I'm a senior member of administration.
Okay.
So I am in those meetings to talk about those things. And I also have peers who are vice presidents over those areas who we are working with right now to identify those needs. We have a huge problem on the hospitalist service with everybody ordering an echo for discharge. Well, they had an echo on admission. The patient has been stable the entire time. They've got, a 20-year history of cardiovascular disease or something, and there's been no dysrhythmia, there's been no change in their cardiac output, vital signs, et cetera, but they're ordering that other echo. Probably is not needed at all. And so she's working with cardiology to identify that criteria. Another one that keeps patients in the hospital so long is telemetry. It is amazing, and that's the #1 bed need we have in the house. And I said, I bet if we develop better criteria, it won't be, because the ED says admit them to MedTele, and they go to MedTele, and maybe they needed it for the first 24 hours. But now it's day 5 and they're still on telemetry. They're still tying up that bed. They're decreasing throughput because really there's been no dysrhythmia. No one's thinking about it. The doctor and the nurse, neither one are thinking about the fact that they're on telemetry and that they don't need to be. We have certain medical groups. This was amazing to me. Very major services who don't make rounds on weekends. They don't see consults on weekends. That's ridiculous. That was a little more difficult, as you can imagine and political to work through. But those are the kind, and she and I will work together on those, because this is a new role for our physician advisor. She's only been in the job since July, and she's doing fantastic. But she needs the political help to go through the hospital administrative levels to make those things happen. Anyone else? All right. Thank you very much.
Thank
Appreciate
you,
your
Bruce.
time. Thank you.
any other questions in the chat, so we will end the presentation. Thank you, everyone.